Thank you. First of all, let me thank everybody for having organized this, and it's a privilege and an honor to be invited and be part of the faculty. And I've heard very good news from yesterday and so far today. So I'm really very pleased and excited, and also very honored to be part of these talks today. Now, the topic is really quite a large topic, and I thought, well, I've got a few things that I wanted to discuss, and then in the video session, I'll try and bring out a few more things which I thought would be a bit more practical. So I thought I'll start with mitral valve repair, giving a surgical perspective. I've always been very skeptical about names and history. Punjabi law states, why the hell did something be named that? So mitral valve has been described as similar to a mitre, a bishop's mitre. And it was Andreas Vesalius, who was a second generation student of Galen, in the manuscript, the Humanis Corporis Fabrica, first edition in 1543, suggested the term mitral. Now, I've put out a few mitres here, so you can make out whether that is really what it looks like. But our knowledge was advanced quite significantly by Leonardo da Vinci's drawings, where he really was able to tell us what is the structure, what is the anatomical structure, and how it would function. And that really started what our understanding of the mitral valve is, which is to be very clear that it's a elliptical shape, and that the shape and the annular dimension undergoes changes during the cardiac cycle. The changes depend on the LV function, the filling volume, underlying pathology, but in a normal mitral valve annulus, you can get a systolic reduction of up to 40%. And the attachment, I won't go into the embryology and the anatomy, but when the common AV valve divides into a two-leaflet mitral valve and a three-leaflet tricuspid valve, again, not at the same level because of the endocardial cushions, the circumference of the posterior annulus is twice anterior. Although we call it an annulus, the recent anatomical drawings tell us that that's not necessarily true. And we've been interested for over 20 years in the mitral valve and have written various manuscripts on degenerative, ischemic, infective endocarditis, rheumatic. And we've grown from the era of 2D echo, where we were able to look at the mitral valve and understand the severity by a quantitative and a semi-quantitative assessment, which was dependent, like I said, on the hemodynamic LV presence or absence of atrial fibrillation, the pulmonary artery pressure, right heart. But it was also able to give us a sense of pathology, i.e., the etiology. And then we were able to look at what the mechanism was, whether it was prolapsing, restrictive, etc. And what happened is the 3D echo came along, and it changed our concept of what the 3D echo should be, and led us to expand that maybe we could use 3D to actually customize procedure. And 3D allowed us to understand the remodeling concept. There is lots in this, and the fact that LV, RV remodeling, and we were able to use three-dimensional in various modes and various modalities, including speckle tracking, that could tell us and understand the pathology and the subsequent repair and remodeling. Now, in terms of pathomorphology, I don't really want to repeat, but this is a very old slide and everybody knows about the mechanisms. The idea is that you perform a repair and support the repair with the help of an annuloplasty ring, which you size on the basis of an anterior leaflet. And there's a very fundamental anatomical reasoning for all that, which we have learned over the years. as to what the truth is and why we use just the anterior leaflet. The surgical techniques for posterior leaflet prolapse were quadrangular resection, but we now dominantly only do neocord. You probably heard respect rather than resect that has been popularized by many authors. And what we have popularized as the P repair, we call it the perfect repair. I'm not saying it is called Punjabi repair, but it is simply to say inspect, respect, resect only if necessary. So it's inspect, respect, and resect, because a lot of times you don't have to. So it's a play on words and a play on different slide technology. As far as anterior leaflet prolapse, most of these are not used now other than artificial chordae. And we also have used occasionally the Alfieri stitch. A lot in my practice, the Alfieri stitch is used more towards the commissure now rather than the middle of A2, P2. Now, this is our technique. This is the Punjabi technique that we've published in the annals as a technique as well as a case experience of using neocordae. Hopefully later on during the surgical videos, I'll be able to show you our technique. There are many to get it right, but this is our technique to get it right. A little bit about the artificial chordae, because that is what it is and that's what we do now. Is first performed in 63 by Kay using silk. Many people then use Teflon, nylon, orthologous, and bovine pericardium. All of them generally failed. I was very fortunate to spend some time with Professor David. Of course, not during the time he used PTFE, but subsequently after using PTFE, he found very good results. And partly the reason for that is PTFE is just Gore-Tex. It has a very porous structure. It allows extensive fibrosis of the neocord, so you have cells invading. And there have been many histological studies of excised specimens by authors and us when we've gone back in for some other reason to excise or replace or re-repair. We have found that the neocord gets completely endothelialized and tends to behave like native chordae. There are many controversies. You may have heard the controversy that when you have an LV which is big, the chordae are long. How come then when the LV gets small, the cord doesn't remain long as compared to a artificial cord which remains long? Many reasons I can discuss at length. It's just a question of time. Like I said, this is our technique that we published way back, and we've got a large number of results on our technique. We use one or more 4050 Gore-Tex sutures into the head of the papillary muscle. All of this is done before the remodeling annuloplasty. If we are doing any kind of excision, then of course you use that space. But the unique thing about us and our technique is that we use horizontal mattress with flagets on the papillary muscle and on the leaflet. Moving on a little bit, I just wanted to talk to you about the ischemic trial. I was very kindly invited to talk at the 2019 AATS and 2020 virtual AATS about Rhine trial and whether it is still relevant. Now, just to remind you, what is the Rhine trial? The Rhine trial was to do with ischemic moderate MR. That has been our focus for over 20 years, and we have one of the largest numbers of cases that we do. Last week we did one, the week before we did two. In the 2012 guideline, there was class 2A that moderate MR should be intervened in patients undergoing CABG. Now, why do we want to do that? Because the idea is that if you don't intervene, now, why is it common? Because it occurs in up to 40% of patients with MI. It can be as a result of LV remodeling and dilatation. The mitral wall is tethered, pulled apart, mild to moderate, but heart failure and death can be increased up to 3 times the moment you cross moderate. Obviously, most have triple vessel disease. Otherwise, it's non-ischemic dilated cardiomyopathy, which is a completely different ballgame, which also we have some work and some experience, including cardiomyopathy and HOCM. But when we were planning the RHYME trial, there was no prospective randomized control. Most of the studies were small. Late MR was either not reported or significant late recurrence was reported. And there wasn't any standardization of what we could do. When we did publish at the American Heart in 12, it was a simultaneous publication in Circulation. And at that time, it was the top article selected by the editors of all the American Heart journals. So what was it? It was a single-blinded randomized controlled trial, randomized into 2 groups, 1:1. One was CABG only. Mind you, these are patients who must have at least moderate MR. So I'll go into the definition of moderate MR, and I have a little bit of understanding of share with you why we changed the definition in the European Society of Cardiology. So CABG only, complete coronary with Lima, CABG plus mitral valve repair. It must be a complete rigid or semi-rigid, no flexible ring. Recommendation was IMR etiologics because it was already downsized. So when you use a sizer to measure, when you take a IMR ring, it is already downsized. But if you don't want to, that's fine. You size by measurement of anterior leaflets, and I can go into the details of why. Downsize by 2 sizes if alternative ring. And the aim is to get a coaptation of at least 8 millimeters, 6 to 8 millimeters. And again, go into that as to what is optimal, what do we use with the rationing between body surface area and coaptation. I've got to be a little bit track of time, so please do tell me if I run overrun. Idea is that you do complete coronary revascularization, complete rigid or semi-rigid, no flexible band, undersized, and no more than trace MR when you're leaving the operation. So you don't have any confounding factor. Patients referred for CABG must have moderate functional. And how do you do that? By an ERO on echo with 0.2 to 0.39, Rigerston volume more than 30, fraction more than 30, and vena contracta more than 0.3. Exclusion, of course, there were certain exclusions because the idea was to try and see whether revascularization and MR. So the primary hypothesis was, does adding mitral valve angioplasties to CABG in patients with moderate functional MR? I can go again into the controversy of moderate and severe and the definition of moderate, but we have done a lot of work. Adding, and the secondary was, does it improve LV reverse remodeling, MR severity, and BNP levels? And we also were going to do peak oxygen and look at various other secondary endpoints at 1 year. We did a power calculation and we planned for 2 interim analyses. And after the second interim analysis with the randomization of 73 patients out of 82, we had to stop because the benefit was far more in patients who were eligible and achieved the target. As you can see, we had more than 50% exclusion because of the severity. One of the key points that we realized was when you put these standard echo moderate MR on exercise echo, it was becoming severe. So halfway I had to go to look for mild on standard echo to get them to moderate on exercise. So that was a couple of reasons. These are just the characteristics baseline. And you can see in terms of surgery, 85% of the patients ended up getting the etiologics ring. And the most important message that you should take from here was that the common size was 28. A large number of the patients admittedly were male, but 28 seems to be the key size. We had a few differences, but none of the differences were significant in p-value terms. But look at this. Look at this in terms of improvement in functional capacity in patients with CABG plus mitral valve. At the end of 1 year, it was quite significant, p of less than 0.001. Even the secondary endpoint, LV reverse remodeling, was great. And we can go into the controversy with Michael Acker. I've been on a debate with Mike Acker at the American College of Cardiology, and we can go into a lot of more detail about that. A lot of the patients who were repaired were, like I said, without less than trace MR, and clearly at follow-up, they did not have MR. NYHA, again, very huge, significant difference and better in patients who had no MR after surgery, and clearly in the group that had mitral intervention. We were expecting a big change in BNP, but this is at 1 year, and maybe it takes longer. The p-value is 0.003, but still there was 10 towards getting better. Symptomatology at 1 year, the previous was earlier, is still better. So we stopped the study early for benefit after review of interim results. It was a single, not a double-blinded, because it's impossible in surgery. One of the biggest editorials that I've written is, how can you do double-blinded studies in surgery when you cannot randomize you cannot blind the surgeon? Endpoints determined at 1 year with longer follow-up necessary, which is going on, and we presented our next phase results at the last AATS, which are showing ongoing benefit. And we concluded that compared to CABG alone, the addition of mitral valve angioplasty to CABG in patients with moderate improves functional capacity, LV reverse remodeling, less of mitral regurgitation or none, and BNP levels tended to improve. We have to wait for the long term. Now, what happened was, this was then used as a reference in the 2014 AHA-ACC guideline, reference 235, that led to the recommendation of 2B that mitral valve repair may be considered with patients with chronic moderate secondary MR who are undergoing other cardiac surgery. But then, obviously, there were two papers that came out, and that changed the ESC and the American College guidelines. One was the 2-year outcomes of surgical treatment, where they involved the importance of decision-making by the heart team and heart failure and electrophysiology, and that surgery is more likely to be successful when myocardial viability is present. But what we found when we went back, considering the fact that our results were so much in favor, and the controversy with the two manuscripts of Mike Acker, and then, of course, the controversy between the COAPT and the MITRA-FR trial, what happened is we went back and we looked at everything, and we found that in the 2017 focused update, they said that the usefulness of mitral valve repair is uncertain, and that 71, 72 were the Bob Mickler's paper and Peter Smith's paper, which was with Mike Acker, to say that they did not find such better improvement as we did. The reason this is important is that because if you wait for too long for the patients to get severe and end up replacing the valve, you can see this is from the society, our data, which says that the patients who have mitral valve replacement, obviously with critical preoperative states, has almost a 3-time morbidity and mortality. And if you look at the National Heart Failure Audit, you find that there is a large number of patients who have either repeat hospitalization or mortality in heart failure with valve disease, and valve disease is present in 40% ischemic patients and quarter of the patients with ischemia had valve disease. So are the results of Rhine trial still relevant? And if the problem is of assessing the moderate MR, what are the pitfalls? So how to assess? You need to be very clear about the patient's, take the patient's global history. Signs, symptoms, is the patient had previous episodes of heart failure? What is the rhythm? Is he sinus rhythm? Is he atrial fibrillation? Look at the angiogram, because to expect that simple revascularization will treat your MR, but if your coronary anatomy is bad, then there won't be much improvement of revascularization. And by default, that will mean that remodeling will not be good. And by default, that MR is not going to get better. So you must intervene in that. What we found very helpful, and I'll show you a manuscript where we wrote the criteria, which is CMR, and the presence of scar and the presence of LV dimensions. LV systolic dimension and LV diastolic dimension. LV systolic of more than 60 was almost guaranteed that you either have to intervene with replacement, or you there's no way you can get away without intervention. We also looked at Rick Nishimura. Rick is the Mayo Clinic chairperson of the American College of Cardiology. So I went and visited him, and we wanted to understand why there was such a significant reversal in the guideline. And then we found that in terms of assessing the secondary MR, because this was what they were talking about, that generally cardiologists, echocardiography standard is not able to understand the severity. And that's because PISA, is a calculation based on a round orifice, whereas an ischemic MR is not a round orifice. And so the PISA can underestimate the severity. The ERO, more changes in heart failure, but for calculation is assumed to be similar throughout. And so when you calculate the regurgitant volume, this can again underestimate. And so we were able to say that in patients who have poor outcomes in ischemic MR, they also occur at lower secondary levels as compared to primary MR. And so you should not. So we then went back to the European Society of Cardiology, a group of people, including myself, and said, hang on, we need to decide this. So this is what we came up. This is table 1. And we said that when you're identifying secondary MR, if you want to define severity, look at this. This is echocardiographic criteria for definition of severe MR. Okay. For primary, you can use an EROA of more than 40. But when you're talking about secondary, you have to reduce it to half, 20. Regurgitant volume, more than 60. But in secondary, half, more than 30. When you want to look at cardiac chamber enlargement, we have got some more charts which give you the measurements. But we were able to say that all those 2 manuscripts that Mickler and Acker were talking about, if you look at the group that failed, and those failure patients, they actually had worse quality of life. So assume that they did not have any intervention, which means that even if you intervene and leave a patient with mild to moderate MR, they have bad outcome. So if you're leaving mild to moderate MR after surgery has bad outcome, how can it not have bad outcome before surgery? So it will. So you must think about intervening. Then we went off, Jean-Francois Obadia is a close friend of mine who did the MITRA FR, and then we went off to talk to them with the COAPT and the MITRA FR trial. And you can see that when you're doing the trial in patients with moderate severe and severe MR, there's still a 47% reduction, a 38% reduction in mortality. All it means is that moderate MR must still be intervened. Moderate MR must still be intervened. You cannot not intervene in moderate. You have a benefit of 30% mortality. That cannot be disregarded. And then they said the reason the MITRA-FR and COAP trial, Milton Packer is a visiting professor at the Imperial College, and we had a lot of email chat, and then we sat down to discuss, and this is what was the outcome, which blamed or which tried to differentiate the evaluation on the basis of ERO as compared to in the two trials. And if you see that in both are MR, severe MR, but in patients with a very dilated ventricle, the COAPT has better results as compared to not. And the ERO makes the critical difference that if you cross the ERO of 0.2, then you will have a better outcome as compared to not. So Rhine trial was relevant, is relevant, now more so as we understand the complexity of evaluation. Patients with ischemic MR, which is ERO more than 0.2. Now, I don't really want to go into whether you call them moderate or severe because I've given up. We tried to label it severe, and the echocardiographer came back to say, but on primary, I'm calling it moderate. Okay, don't worry. Just put us a number and we will tell you what to do. Mild MR, clearly to be left alone. If there is any evidence of heart failure, please do. Do not leave any residual MR untreated or recurrence has high morbidity. Move away from pure survival. You will see survival benefit if we intervene early. Success is not final, failure is not fatal, is the courage to continue that counts. And if I have made enemies, good, thank you. That means I've stood up for something sometime in my life. Thank you very much. Thanks for this privilege and opportunity. And I really would like to thank the organizers, both on the UK side as well as the Egypt side, and giving me this honor and opportunity. Thank you very much.